Good morning, everyone. Welcome to today's session on key ethical implications of substitute decision-making in guardianship. As you get settled in for the day, I'm going to go ahead and pop in our event materials, um, where you can download our PowerPoint slides, and we're going to talk about CEUs at the end of today's session, but I just went ahead and posted in the chat a link to the event page where all of our materials and information we're discussing. So welcome, welcome. We have a good crowd on today. We're excited. My name is Rachel Browner, and I'm the program coordinator for OneOp, and it's my pleasure to welcome you to today's session on key ethical implications of substitute decision-making in guardianship. If you're joining us for the very first time, I'd like to give you a brief tour of our webinar platform so you can find your way around. So we can go to the next slide. Hopefully you're currently able to view the slides that we're sharing. If you're unable to see them or if you have any other difficulties, please email us at contact@oneop.org for tech support. And as some of you have already been doing so in the chat, we look forward to having you join us there for conversations and questions. To embed that chat pod so you don't miss any links or conversation, simply place your cursor over the shared slides. You'll then see a toolbar pop up across the bottom of your screen, and from there, just click that chat bubble icon. So when typing questions or comments, please be sure to select the Everyone from the Response Options drop-down menu so everyone's able to view them in the chat. And note that the slides and resources, as I mentioned, are available for download on the event page for today's session. And we'll be covering continuing education opportunities, which we have several CE opportunities for those of you interested. And we're going to save that information till the very end. So please stay tuned. If you're interested in CE credits or General Certificate of Attendance, stay tuned. And finally, closed captioning is available for this webinar, and you can turn on the subtitles via the Zoom toolbar. And so some of you have already been go ahead and posting where you're joining us from. Let us know who you are, maybe what organization or where you're located at. It makes this platform a little bit more personal, kind of gives us an idea of who's on with us today. And the presenters for today also gets to see that as well, who's joining us. So we appreciate it. I'm actually here in College Station, Texas. So shout out to some fellow Texans that I see, but it's great to see folks from Washington, Alabama, South Carolina, Wisconsin, snowy Wisconsin, New Jersey, Arkansas. So it's great to see that we have a good diverse group on today. And thank you for joining us as we continue our partnership with the Department of War and the U.S. Department of Agriculture to expand the readiness, knowledge, and networks of the professionals supporting our military service members and their families. Please know the views expressed in this presentation do not necessarily reflect the official policy of the Department of War, U.S. Department of Agriculture, U.S. government, or OneOp. And the mention of any entity or product is for informational purposes only. At this time, I'd like to go ahead and introduce our presenters for today. We're very excited to have Miss Lorna Lee Riley, as well as Dr. Robert Franklin as our two presenters from today. Miss Riley received her Bachelor of Arts from Mount Holyoke College in 1986 and her Master of Science in Social Work from Columbia University School of Social Work in 1990. She's a licensed clinical social worker and certified case manager, and she actually started her social work career in the AIDS program at St. Luke's Roosevelt Hospital during the height of the AIDS pandemic. After that, she's worked as a geriatric social worker at Emblem Health, where she was instrumental in the creation and implementation of the company's first end-of-life care program called Dignified Decision. Miss Riley then moved into the acute care settings as Director of Social Work for several large New York area healthcare systems. Her accomplishments during this time, including heading of a hospice care program where she was instrumental in developing, implementing, and overseeing the first comprehensive program, an enhanced interdisciplinary care team where she concentrated on medically and psychosocial complex patients to ensure a timely and safe transition to the next level of care. Joining her, as I mentioned, is Dr. Robert Franklin. Dr. Franklin is a licensed psychotherapist with his doctorate in counseling from St. Mary's University. Dr. Franklin is originally from Louisiana and raised in a military family and has made San Antonio, Texas, his home since 2001. He's supported individuals, couples, and families across a range of settings, including employee assistance programs, varied levels of care and mental health, university counseling center, clinical case management, and military and government environments. And Dr. Franklin specializes in operational stress, life transitions, couples therapy, case management, clinical supervision, and minority challenges. And he really believes in creating a respectful and empowering space for clients to build healthier relationships and more satisfying lives. So without further ado, I'd like to go ahead and pass over the presenter reins to our two presenters to begin for today's session.
Good morning and welcome. Keith, I'm not sure if you are
Oh, sorry. That
okay.
I was all talking and I didn't even hit the unmute button. That's my technology issues. I was trying to say welcome everybody, and like was mentioned earlier, I am a Texan at least for the last 2 decades. But having grown up in a military family, I got to move around quite often as well. I'm really happy to be part of this presentation today. And being part of the Department of War right now, it helps to be a contributing force to this sharing of knowledge. So we will do that. Um, so I wanted to start off by just framing up what we're going to be discussing today. The purpose of the training has three primary goals. That's to strengthen our ethical reasoning, to reduce any legal or professional risk, and to promote patient-centered and rights-respected care. These are some tenets that we want to basically hit home to you today when we are able to share along with you uh, the, uh, the overall conversation around I'm trying to I want to use the most sensitive of words, but we are really talking about consent and capacity today. So those are going to be some of the key tenets of today's conversation. What can you expect today? So we're going to help you define some definitions that are some are going to be overt and some are just going to be clarifying. We're going to discuss decision-making capacity, informed consent, and also the conversation around substituting and supporting decision making and guardianship. We will distinguish between surrogate hierarchies and court appointed authorities. We will discuss core ethical principles that affect real world scenarios. And we will use structured ethical decision making frameworks that help analyze complex cases. This session is designed to be practical, so we really, really hopefully want your engagement, so that way we're not talking at and we're talking with. We probably have a lot of smart people on this call, and your real world experiences can help integrate into today's discussion. Because these will basically framework our capacity to evaluate for capacity. I'm sorry. So we have some key learning outcomes that you'll see on your screen. The first one being that of defining the key concepts, like I mentioned. We will also distinguish those among the surrogate decision makers and their guardians, and as previously mentioned, the ethical principles as it relates to real world scenarios that involve vulnerable adults and their dependents. Next slide. So we start off with the very basic question: what is decision-making capacity? It is a definition, um, but it is a clinical determination and not a label. Is the first thing that we want to start off with. The clinical determination is about an individual's ability to make a specific decision, and here I'm going to be very clear: a specific decision at a specific time. And it's very, I want us to hold on to that piece because that's going to come up throughout our conversation today, because it's foundational to getting a valid informed consent and becoming important when it comes to capacity, when capacity is questioned, impaired, or fluctuated. It is important also to distinguish between clinical capacity and legal competence. Clinical capacity is determined by healthcare professionals, and a number of you on this call are deemed healthcare professionals. It's assessed in relation to a specific medical decision, usually at the bedside or in a clinical setting, and the clinician evaluates whether the patient can meaningfully participate in decisions about their care, and that determination is documented in the medical record. Here's another one I want to hit home with you guys. Capacity is not an all or nothing. It can vary depending on a situation and the complexity of the decision, and it can change over time. So here I'm going back to that specific decision at a specific time. Legal competence, on the other hand, is a judicial determination made by a court. If a court finds someone legally incompetent, it may appoint a guardian or conservator to make decisions on that person's behalf. So here's the key distinction. Clinical capacity is determined by clinicians, legal competence by courts. That is an easier separation of those two conversations. Again, capacity is a decision specific, and competence is typically very global. Capacity can fluctuate. Legal incompetence generally remains in place unless modified by a court. Capacity does not require court involvement, while incompetence does. So we have our clear distinctions. Capacity is clinically driven, and competency is court and legal driven. A patient may lack clinical capacity for a complex surgical decision, yet still be legally competent. Conversely, someone under guardianship may still retain capacity for certain day-to-day decisions. Understanding this distinction helps us avoid unnecessary referrals for guardianship and supports the ethical principle of autonomy by preserving rights whenever possible. What does it mean to say capacity is task specific and time specific? Does anybody want to give a jab at that? What does it mean to say capacity is task specific and time specific? Specific, if I can put it out of my head. Well, as you guys think over it, I want you to think of capacity is generally a functional assessment, not a diagnosis, which we in the healthcare realm tend to lean into diagnosis. Not to say that that is not an element, but a capacity is a functional assessment. Task specific means an individual may have capacity for some decisions, such as choosing what to eat or consenting to a blood draw, but lack capacity for higher risk decisions, like refusing life-sustaining treatment or consenting to high-risk surgery. The greater the complexity and the risk, the higher the level of understanding and reasoning is required. Capacity is also time specific. It can fluctuate due to conditions, examples like delirium, medication effects, acute psychiatric episodes, pain, fatigue, stress, infection, or even traumatic brain injuries. A patient who lacks capacity in the morning due to delirium may regain it later in the day. Capacity is dynamic and requires reassessment rather than permanent labeling. As clinicians, we both have a clinical and ethical obligation to treat reversible causes, optimize communication, and reassess when conditions improve. Prematurely defaulting to surrogate decision-making when capacity may return, we risk violating the patient's autonomy. Keeping this framework in mind helps us ensure we protect both patients' rights and clinical integrity as we move forward. So now I want to go over a little bit of the I want to make sure if you have questions as I go along, please jump up, throw them into the chat, and we'll have some of our lovely colleagues kind of pause me and throw out questions as we go along, or if you want to write them down and return them to the end for our Q&A, that'll be helpful as well. But I want to make sure that if you guys have any type of engagement or conversations you want to add to the topics on the slide, again, this is a discussion. I really am not in the business of trying to talk at people. It's not my jive. Okay, so now we're going to go over those core elements of capacity. So now capacity assessment is both a clinical skill and an ethical safeguard. When done thoughtfully, it protects patients, families, and professionals and upholds the integrity of patient-centered care. There's a widely accepted 4-part clinical framework for assessing capacity. That is understanding, appreciation, reasoning, and communication of a choice. Let's walk through each briefly for your own personal understanding. First, understanding. Can the individual comprehend the relevant information? The patient must be or client in case must be able to grasp the nature of the condition, understand the proposed intervention, recognize the risks, benefits, and alternatives, and understand refusing treatment is also an option. As you'll notice, the word understand comes up quite a lot. This requires functional comprehension. A helpful strategy is to ask the client or patient to explain the information in their own words. We want to avoid yes and no questions, and we want to use plain language when needed. For example, can you tell me what you understand about the procedure we discussed? If they can accurately restate the essentials, understanding is likely intact. Second, appreciation. Appreciation goes beyond intellectual understanding. It involves insight. Does the patient recognize how the information applies personally? For instance, a patient may understand that chemotherapy treats cancer, but deny that they themselves have cancer despite clear evidence. In that case, understanding may be intact, but appreciation is impaired. Impaired appreciation often seen in conditions such as psychosis, severe mood disorders, neurocognitive disorders, or brain injury. Things you might ask could be, for example, what do you believe will happen if you choose not to proceed with this treatment? You're assessing whether they recognize the personal consequences of their decision. Third, reasoning. Reasoning involves the ability to weigh risks and benefits, compare alternatives, and explain a choice in a way that aligns with personal values. The decision does not need to match the clinician's recommendation. Patients are allowed to make decisions others consider unwisely as long as the reasoning process is intact. A useful question is, can you walk me through how you decided this was the best option for you? Look for logical consistency, the ability to consider consequences, and a clear explanation for preferring one option over another. If the assessment is unclear, it's appropriate to consult with another clinician, such as a psychologist, a psychiatrist, neurologist, or other relevant specialist. Fourth, communication of choice. Can the patient consistently communicate a decision? The patient must be able to clearly state a preference, maintain consistency over time unless new information emerges, and communicate in any reliable way, verbally, in writing, or through assistive technology or even gestures. It's essential to distinguish communication barriers such as aphasia, language differences, or hearing impairment from true cognitive inability. Reasonable accommodations must be made before determining lack of capacity. This supports justice and equity in care. What are the ethical implications that are involved in this process? Assessing capacity is not just procedural, it's an ethical responsibility. We begin with the presumption of capacity and honoring autonomy unless there is clear evidence to question it. Beneficence and nonmaleficence remind us to protect patients from harm when decision making is impaired. Justice requires that we avoid assumptions based on age, disability, diagnosis, or social status. And fidelity calls us to document thoroughly and transparently. Overestimating capacity can expose patients to harm, but underestimating capacity can strip individuals of fundamental rights. Our task is careful, structured, and is a well-documented assessment, never an assumption. Capacity versus competency is going to be, come up like I mentioned at the beginning over and over again, but I want to be very clear as this is helpful for us as providers because sometimes we can jump into the world of competency and we want to make sure these are two distinguished pieces. So I want to clarify the distinction between capacity and competency because it directly affects surrogate involvement and guardianship decisions. As we mentioned at the top, capacity is a clinical determination. It asks, can the patient make this specific decision at this time? It is decision specific and again can fluctuate. For example, here's a real life scenario. A patient experiencing an acute PTSD crisis may lack capacity to refuse hospitalization due to impaired reasoning. But after stabilization, that same patient may clearly understand risks and alternatives. Capacity is reassessed and found to be intact, and the condition changed, so capacity changed. Competency, in contrast, is a legal status determined by a court. If someone is found legally incompetent, a judge may appoint a guardian or conservator. This determination is broader and remains in place unless the court modifies it. So we are not involved in the court's determination. Importantly, a patient may lack capacity for one decision, but retain capacity for others. And that becomes a little bit of the gray sector for us. Someone might consent to a routine blood test, but lack capacity to refuse life-sustaining dialysis. Even a person under guardianship may still decide what to wear, whether to participate in therapy, or whether to accept visitors. Guardianship does not eliminate all decision-making ability. Ethically, this reflects the principle of the least restrictive alternative. Preserve autonomy wherever possible and limit intervention only to what is necessary to protect the individual. I'm looking at some of your chat, so because you guys are offering some really good stuff.
And Dr.
Oh, so
Franklin, oh, go ahead.
yes.
I was
No,
going to
no, you
say
go ahead, ma'am.
we do have a kind of a scenario that Deb Bruschi mentioned in the chat, and so I'm hoping
That's what I
maybe
was
we
trying
can
to read.
hold, yeah, I'm hoping maybe we
Yeah.
could hold that to the very end since this is a
Okay.
very specific scenario and situation that's a
I like it.
personal experience. Yeah, we'll hold that to the very end, Deb. And I have made note of this for the very end
No
to be able
problem.
to cover it.
Sorry, I'm also for those that are joining us, I'm trying to track your conversations at the same time, but I also want to make sure I speak to all the tenants that are vital to you to the conversation today. So this next slide goes over those common causes that can affect impaired capacity. Some are very specific to my training, and then of course some are specific to some of you that may have the specific to medical. So I want to discuss these common causes, or at least the most common ones, like I said, mentioned. So impaired capacity arises from a lot of conditions, and we recognize the cause. Recognizing the cause is critical because some of the impairments are temporary and reversible. So first, we're looking at these neurological or psychiatric conditions. Conditions such as traumatic brain injury, PTSD, severe depression, substance use disorders, psychosis, or mania can impair understanding, appreciation, or reasoning. For example, a service member with a recent TBI, a traumatic brain injury, may struggle with short-term memory and be unable to retain information about surgical risks long enough to compare options meaningfully. As neurological recovery progresses, capacity may improve over time. A patient with severe depression may refuse dialysis, saying, "It doesn't matter, I'm worthless anyway." That refusal may reflect distorted hopelessness rather than balanced reasoning. After appropriate treatment, the patient may regain capacity to reconsider. Another example, substance intoxication. A patient under the influence of alcohol refuses imaging after head trauma. Understanding and reasoning are impaired. If clinically safe, capacity assessment should be deferred until sobriety occurs. The next area that I want to talk about is cognitive impairment. These cognitive conditions can include dementia, stroke, and delirium, and can affect decisional ability. Examples: an older adult with moderate Alzheimer's disease may believe she is 30 years old and deny having a heart disease. Appreciation is impaired because she cannot connect information to her current reality. Delirium is especially important. A hospitalized patient with an infection-related delirium may believe staff are imposters. Because the delirium fluctuates and is often reversible, reassessment after treatment is ethically required before defaulting to surrogate decision-making. I want to pause here and just to and reiterate there is a time involved in this, and I know depending on a variety of our settings, time is of the essence, but we still want to maintain that ethical principle of allowing to take that time to be able to reassess before we default to that surrogate decision making. Third, let's go over developmental and intellectual disabilities. A diagnosis alone does not equal incapacity. Capacity must be assessed functionally. An adult, for example, an adult with mild intellectual disability may fully understand a proposed dental procedure and explain the risks and benefits in very simple language, demonstrating capacity. That same person may struggle with complex chemotherapy regimen. Supported decision-making tools such as visual aids, simplified explanations, or trusted supporters may enhance this capacity. Again, going back to that justice principle, requiring that we avoid discriminatory assumptions based solely on diagnosis. Finally, one of the common causes associated to acute medical crises, pain, medication effects, or stress. These can temporarily impair capacity, even in individuals with no underlying psychiatric or neurological disorder. We all know that pain creates a little bit of a dysphoria for us. So severe pain, hypoxia, sepsis, post-anesthesia effects, opioids, sedatives, sleep deprivation, or emotional shock can all interfere with decision making. A patient in extreme pain from a fracture who says, just do whatever, they may not be able to process the risks and alternatives. Treating pain first may restore their capacity. Similarly, come on, I can spit it out. I know it. Similarly, a patient heavily sedated on opioids who attempts to sign out against medical advice may not be able to remain awake for a risk discussion. The decision should be delayed until the medication effects diminish. We want to be careful. A structured assessment protects both patient rights and our professional integrity and helps prevent unnecessary guardianship referrals, ethical violations of autonomy, legal risk, and lastly, the erosion of patient or client trust. I want to hand it over to my colleague to continue our conversation.
Thank you, Keith. So we're going to segue into informed consent as an ethical and legal foundation. So informed consent is both an ethical obligation and a legal requirement. It isn't simply a signed form. It is an ongoing process of communication. So when done well, it protects patients' autonomy or clients' autonomy. It strengthens trust, it reduces liability risks, and enforces professional integrity. However, when done poorly or bypassed without justification, it can become a common source of ethical conflict and legal exposure. So, valid informed consent requires five essential elements. If anyone is missing, consent may not be ethically or legally sound. So, one of those first essential element is disclosure. A patient must receive relevant information about the nature and purpose of that intervention, material risks, expected benefits, reasonable alternatives, including no treatment if the patient so choose, and the potential consequences of refusal. So, disclosure should reflect what a reasonable person would want to know to make an informed decision. A patient, for example, a patient considering spinal surgery must be told not only the success rate, but also risks such as infection, nerve injury, persistent pain, and the option of continued conservative management. Withholding information because it might discourage the patient or their client undermines autonomy and increases liability risk. Second is the patient willingness. The decision must be made free from coercion or undue influence. Consent is not valid if the patient feels pressured by family, institutional authority, artificial time urgency, or financial incentive. Our role is to ensure that decisions reflect the patient's value, not someone else's agenda. Third is understanding. Information must be presented in a way the patient can comprehend. Understanding cannot be assumed simply because information was delivered or the person is nodding in agreement. Best practice include using plain language, avoiding jargons, using teachback, provide interpreters when needed, and offering written or visual aids. If a patient nods during a discussion of anticoagulation risk but cannot later explain what bleeding risks mean, the clinician must reassess comprehension. Language barriers, hearing impairment, and low health literacy must be addressed before consent can be considered valid. And fourth, decision-making capacity. The patient or client must be able to understand the information, appreciate how it applies personally, reason through options, and communicate a consistent choice. If capacity is impaired, consent cannot ethically or legally be obtained directly from that patient or that client. So a patient with acute delirium may sign a consent form while believing staff or actors in a simulation has not provided valid consent, regardless of the signature. And documentation. Clear, timely, and accurate documentation should reflect the information disclosed or discussed, questions asked and answered, assessment of capacity, confirmation of willingness, and the patient's decision whether consent or refusal. The consent form is evidence that a process occurred. The consent form is not a substitute for that process. So thorough documentation protects both the patient or the client's rights as well as the professional accountability. It also reinforces that informed consent is a meaningful ethical process, not an exercise in paperwork. So I'm going to review a few of these ethical principles in terms of consent. So first, we're going to look at autonomy. And Keith had earlier discussed a little bit about autonomy. And autonomy is really respecting the individual's right to self-determination. Patients and clients have the right to make decisions consistent with their values, even when we as clinicians disagree. The provider may believe treatment is the better choice, but if capacity is intact, the patient decision must be respected. Beneficence. Beneficence is acting in the patient's best interest, promoting well-being and recommending interventions that offer clinical benefit. For instance, recommending hospitalization for a suicidal patient may reflect beneficence because it reduces immediate risk of harm. However, beneficence does not automatically override autonomy. It only justifies overriding a patient's choice when decision-making capacity is impaired. And nonmaleficence, first do no harm, and we all are familiar with that. This includes avoiding unnecessary procedures, harmful delays, neglect, failure to treat, or coercive or traumatic interventions. It is, even if surgery is technically unsuccessful, proceeding without a proper consent can cause psychological and ethical harm. Justice. Justice requires equitable treatment and equal respect. It means avoiding discrimination and not making assumptions about capacity based on age, disability, race, or diagnosis. Assuming an older adult would not understand anyway and defaulting to family consent without assessment violates justice. Every patient deserves an individualized evaluation. And finally, fidelity. Fidelity is about maintaining trust, honesty, and professional responsibility. It requires truthfulness, transparency, follow through, protection of confidentiality, and honoring commitments. If a complication occurs that was not previously discussed, fidelity requires honest disclosure, not concealment. Concealment erodes trust and increases legal risk. These principles form the ethical foundation of informed consent and guide us when tensions arises between patients' choices and clinical judgment. So, when consent cannot be obtained, what to do when informed consent cannot be obtained directly from the patient? There are two main scenarios where informed consent can be obtained. cannot be obtained, excuse me. One is during an emergency, and the other is use of a surrogate decision maker. So emergencies are true emergencies where treatment may proceed without a formal consent if immediate action is necessary, delay would risk serious harm or death, the patient lacks capacity, and no surrogate is immediately available. An unconscious trauma patient with internal bleeding may require immediate surgery to save their life. Waiting to locate a surrogate would increase the risk of death. But the emergency exception is also narrow. It does not apply simply because obtaining consent is inconvenient or time consuming. Once the patient stabilizes, consent must resume as an ongoing process. Surrogate decision making. When a patient lacks capacity and there is no immediate emergency, decision must be made by a legally authorized surrogate, such as a healthcare agent named in an advance directive, a durable power of attorney for healthcare, a court-appointed guardian, or a statutory defined next of kin. The surrogate must follow either a substituted judgment or a best interest standard. So, a substituted decision judgment is deciding what the patient would have wanted, and a best interest standard is deciding what most promote the patient's welfare when prior wishes are unknown. So, if no prior wishes are known, the surrogate must weigh prognosis, burden, benefits, and quality of life to determine the best interests of the patients. So it is critical as clinicians that we verify the surrogate's authority, provide full disclosure, ensure the decisions align with the ethical standards, and intervene if a surrogate choice clearly endangers the patient. Even when consent cannot be obtained directly, we are still obligated to protect that patient's rights it becomes even more important during that time. So I'm going to review a little about the informal surrogate decision maker. So when a patient lacks decision-making capacity and informed consent cannot be obtained directly, a substitute decision making becomes necessary. Not all surrogate carries the same authority, and it's important to remember that. And not all decisions follow the same ethical standard. Understanding who may decide and how decisions should be made is essential to protecting the patient's rights while minimizing ethical and legal risk. So informal surrogates are typically recognized through state default hierarchy statutes when no formal documentation exists. They are often family members or next of kin. They typically include a spouse or domestic partner, adult children, parents, or other next of kin such as siblings. It is very important to know that authority varies by state, hierarchy orders matters, equal ranking surrogates may create conflict, informal surrogate must still follow ethical decision-making standards, not personal preference. So formal surrogates. Formal surrogates derives their authority from legal documentation or court order. A formal surrogate could be a medical power of attorney, and this allows a patient to designate someone to make healthcare decisions if the patient loses capacity. The key point is that the authority only activates once capacity is lost. As clinicians, we must verify three things. Is the document valid? Has the patient met the threshold for incapacity? What is the scope of the authority? The next is a durable power of attorney, and this may occur to cover finances, healthcare, or both, depending on how it is written. The key here is to confirm that the documents specifically include healthcare decision-making authority, because not all durable power of attorney has that in documented. And third is a court-appointed guardian. And this guardianship is established through a judicial process, as Keith mentioned. And the authority may be a full guardian, also called plenary, or a limited guardian, and that is limited to certain areas. Even under guardianship, we still should encourage the patient's participation to the extent possible, still verify the exact scope of the guardianship authority, and that is usually written in that guardianship document. And you should always ask for that document if someone claimed that they are the guardian of your patient or your client. And you must still apply the least restrictive principle. And finally, advance directives and living wills. They are documents that allow patient to express their treatment preferences before losing capacity. They allow the patient's voice to remain central even when they no longer can speak for themselves. Living wills often address end-of-life decisions such as mechanical ventilation, artificial nutrition, and resuscitation. It is vital to remember and to be aware that what your state laws states about living wills, particularly regarding artificial nutrition and hydration.
Miss Riley, we did have a question in the
Sure.
chat from Kaylee. If a married couple gets divorced but has a medical POA, does the POA still stand for decision making?
Yes. If the individual clearly indicate who they would like to make decision, that still stands. It's important to validate the date. What I've also encouraged my staff, if you're in doubt as to the validity of that documentation, you should speak to your organization, risk management, or your legal counsel to be on the safe side.
We also just had a comment from Barb in the chat to just consider that there are two categories under full guardianship. So full and expanded guardianship and requirements vary by state. So
Mm-hmm.
for example, in her state, guardians cannot make end of life decisions on behalf of an individual without expanded guardianship.
Yes, so that's why I mentioned earlier, it's very important to know what your state guidelines are regarding these documents. Every state have different requirements as to what the guardian is allowed to do or not allowed to do. The document itself, at least I know in New York, whenever we have a document of guardianship, we go through it because in that document, it would clearly outline the authority of that guardian. So we're going to move into decision-making standards. And once a surrogate decision maker has been identified, the next question should be, how should decisions be made? There are three primary ethical standards that guide this decision. One I've already mentioned, which is the substituted judgment standard, which is a preferred standard whenever we know enough about that patient's value, their beliefs, or prior statements. The goal is to make the decision the patient would have made, not what the surrogate prefers. And the surrogate's role is to stand in the patient's shoes. It is about honoring that patient's known wishes. The other is the best interest standard, and this is used when a patient preference are unknown. In these cases, decisions should focus on overall well-being, risk and benefit analysis of the treatment, relief of suffering, preservations of function, and the quality of life of that individual. For example, an unconscious patient with no family and no advance directives requires a decision about may require a decision about a limb amputation due to a life-threatening infection. Without known wishes, the team must weigh survival benefit, functional outcome, and prevention of harm. Best interest does not mean maximum treatment. It means a balanced, ethically ground evaluation of what most support the patient's welfare. And last, the least restrictive alternative principle reminds us to preserve as much autonomy as possible. As clinicians, to do so, we should avoid unnecessary guardianship referrals, use supported decision making when feasible, and reassess capacity regularly. Limit surrogate authority to what is absolutely necessary. So let's consider another scenario. This is of a patient with severe depression who temporarily lacks capacity to refuse life-sustaining treatment. The spouse is identified as a surrogate and says he always said he wants everything possible chance to recover. Using substituted judgment, treatment proceeds. As the depression improves, the patient regains capacity and resumes decision-making authority. The surrogate's role ends at that point, and this is crucial to underscore. Once the patient regains capacity, you should be engaging the patient around treatment decision, not the surrogate. So guardianship, what is guardianship? It is a court-ordered legal relationship in which a judge determines that an individual lacks sufficient capacity to manage personal, medical, or financial affairs and appoints another person, the guardian, to make decisions on their behalf. As mentioned, it is not a clinical determination. It is a judicial action that removes or limits someone's right. So guardianship is one of the most restrictive intervention in substitute decision making. While sometimes it is necessary to protect vulnerable individual, it represents a significant limitation on someone's civil liberties. Ethical risks include loss of autonomy, exploitation, and overreach. Because of its gravity, guardianship should be approached with careful ethical analysis, procedural rigor, and consideration of the less restrictive alternatives. Apologies. So what are the types of guardianship? First, as mentioned, full or planetary guardianship. So full guardianship grants broad authority over personal, medical, and sometimes financial decisions. Depending on your jurisdiction, as the person earlier mentioned, each state have regulations governing their guardianship procedures and um, giving rights. So the individual may lose the right to enter into contract, make healthcare decisions, manage finances, determine where they live, and in some cases, even who to marry or to vote. Because it removes so many civil liberties, full guardianship should be reserved for a situation where capacity is profoundly and permanently impaired across multiple domains. It is a significant intervention and should never be treated as routine. Limited guardianship restricts authority only to specific areas when incapacity has been clearly demonstrated. The individual retains decision-making rights in all other areas. This approach preserves autonomy whenever possible. And third, temporary or emergency guardianship. These are short-term and typically used in urgent situations requiring immediately protection. It may be granted when there is a risk of exploitation, when immediate medical decisions are needed, or while a permanent guardianship hearing is pending. So if an adult with acute psychosis is being financially exploited and refuses necessary medical care due to delusional beliefs, a court may appoint an emergency guardian for a short period while evaluation is conducted. So short-term protection should remain short-term unless clearly justified. So before pursuing guardianship, ask, is incapacity clearly established and persistent? Have reversible causes been addressed? Have supported decision-making options been attempted? Is the guardianship limited to only what is necessary? Does this align with the least restrictive alternative principle? So what are some of the ethical challenges to guardianship? So one of the ethical challenges is the loss of autonomy and civil rights. So guardianship, even when well-intended, fundamentally alters an individual legal identity and independence. The ethical tensions here lies between limiting autonomy in order to provide protection. Another is risk of abuse, neglect, or exploitation. Guardians might have significant authority, and without proper oversight, that authority can be misused. Risks include financial exploitation, overly restrictive living arrangements, medical decision inconsistent with the individual's values, and social isolation. Third is overuse when less restrictive options are available. So guardianship is sometimes pursued for convenience rather than necessity. Contributing factors may include family conflict, institutional pressures, misunderstanding of capacity, or a desire to streamline decision making. So ethically, guardianship should be the last resort, not the first step. And finally, you may have cultural and family conflicts that can implicate these decisions. Loyalty expectations, stigma around mental health, or cultural beliefs about authority may influence a family to seek guardianship permanently. For example, if you have a patient with PTSD refuses treatment, family members push for guardianship to restore order. However, the patient refusal may reflect intact capacity and personal value, not incapacity. So as clinician, we must carefully distinguish between disagreement with a decision and genuine inability to decide. Guardianship should never be used to override value-based decisions simply because they make others uncomfortable. So what are the alternatives to guardian? One such alternative is supportive decision-making agreement. So the supported decision-making allows individuals to maintain full legal authority while designating a trusted supporter to help them understand information and complicated decisions. The next is this approach also protects that person's dignity and their rights. Please don't overlook case management and interdisciplinary support. Sometimes what appears to be incapacity is actually a support gap. Social work coordination, behavioral health treatment, financial counseling, community resource linkage, or cognitive rehabilitation may stabilize functioning and provide support needed. And third, limited conservatorship where available. In some jurisdictions, conservatorship may focus specifically on financial management while leaving healthcare decision-making intact. Imagine an older adult who repeatedly falls victim to financial scams but clearly understand and manages healthcare decisions. A limited conservatorship can protect assets without interfering with medical autonomy. And a representative payee. For those individuals receiving government benefits, a representative payee can manage funds without imposing broader guardianship, power of attorney, and protective advanced planning. It's very important to encourage your patients and your clients to complete a medical power of attorney, a durable power of attorney, advance directives, or living will before a crisis occur that can prevent the need for guardianship. Planning ahead preserves control and reduces conflict. So, ethical decision-making framework. When informed consent cannot be obtained or when the situation feels ethically complex, clinician need must be clear. Repeatable framework that promotes consistency, reduces bias, strengthens documentation, and protects both patients and providers. First, start by clearly articulating the core dilemma. Ask yourself these ethical questions. What exactly is the ethical conflict? Is this truly about capacity or about disagreement? Is there tension between autonomy and safety? Are we facing legal uncertainty? Vague concerns lead to vague reasoning. Precision clearly, Precision clarifies thinking. Take, for example, imagine a patient with severe depression who refuses hospitalization after expressing passive death wishes. The ethical question is not, should we admit him? The real question is, does this patient currently have the capacity to refuse hospitalization? And if not, what is the ethically justified next step? Second is clarifying decision-making capacity and its limitations. Before involving surrogates or considering guardianship, it's important to assess is capacity intact? Is impairment temporary or permanent? Is the decision specific? Are there reversible causes? Consider a patient with sepsis who refuses surgery. During evaluation, delirium is identified. After treatment, the infection and stabilizing vital signs, the patient regained clarity and meaningfully participate in decision making. If reassessment had been skipped, autonomy would have been unnecessarily overridden. And third, identifying stakeholders. Ethical decisions affect multiple parties. They are the patient, family members, legally authorized surrogate, the healthcare team, behavioral health providers, case managers, and sometimes risk management or an ethical committee. Clarifying who has legal authority versus who simply has strong interests prevents boundary confusion. Therefore, it is crucial to review relevant laws, as mentioned, regulations, and organizational policies. Ethical reasoning must align with legal requirements. Consider state surrogate hierarchical law, advanced directive statutes, guardianship statutes, federal protections such as disability accommodations, and your organization's consent policies. If two adult children, for example, disagree about a treatment, state laws may specify how conflicts among equal ranking surrogates must be resolved. Providers should not impose a solution that contradicts your state statute. In highly complex cases, consultation with your organization's legal counsel or risk management might be appropriate. And I'm going to pass the next slide on ethical decision-making framework over to Keith.
Excellent. So now I want us to look a little bit about some of the alternatives that go along with this framework. As we continue to use the structured ethical framework, the next step is an exploration. So we want to explore alternatives, and I'm going to use the term again that you may have seen in some of my responses in the chat, the least restrictive, but in this case, the least restrictive supports. Before restricting a person's autonomy, we want to be able to take a pause. We want to be able to ask ourselves questions such as, can we delay whatever that is occurring until capacity improves? That's a key clinical decision that has to be weighed out in the specific scenario at hand. Can we simplify the information and bring it down to a different level, to a more lay, less clinical? Would supported decision-making help? Is guardianship truly a necessary step? And is there a more limited option? For example, so that way to give a little context to this, a patient with mild cognitive impairment struggles to understand chemotherapy options. Rather than defaulting to a surrogate decision making, the team uses visual aids, breaks the information down into smaller segments, maybe includes a trusted supporter in the discussion, someone who relates with the individual. And with those supports in place, the patient now can demonstrate sufficient understanding to decide. Support preserves autonomy. The least restrictive alternative principle protected this patient's rights in this scenario. Next, we want to apply core ethical principles to help us weigh our options. Systematically, I want you to consider these. I know that these are not always in front of us, but if you have the ability to remember these simple ethical principles, they help us. They're stuff from either back in graduate school days, or for those that are non-clinicians, these are things that clinicians should be taking into consideration, such as autonomy. Does this respect self-determination? Beneficence? Does it promote well-being? Non-malfeasance? Does it avoid preventable harm? Justice? Is it fair? Non-discriminatory? And fidelity? Does it maintain honesty and trust? We want to avoid relying on just one principle. Ethical decisions usually require a balance. If capacity is impaired, a temporary protective intervention may be justified, but only with clear reasoning and documentation. And that itself brings us to making and documenting the decision clearly. Once the analysis is complete, we want to A, state the decision, B, document the reasoning, C, record capacity findings. We want D, note any surrogate authority if applicable. And E, we want to reference any relevant laws or policies when appropriate. That is an especially helpful one when covering for when you're making a decision for covering that authority piece. The document might read, as an example, patient lacks decision-making capacity at this time due to acute delirium, as evidenced by inability to appreciate medical condition and inconsistent reasoning. Spouse identified as legal surrogate under state statute. Treatment decision reflects substituted judgment based on prior expressed wishes. So notice that this reflects structured thinking, not just the outcome. Clear documentation reduces ambiguity and protects our professional integrity. Finally, we want to communicate transparently with everyone involved. Ethical decisions should not occur in silence. Communication should include that explanation of capacity findings, the clarification of a surrogate authority, the rationale for the decision, an opportunity for questions, and a respectful tone, even in disagreement. Another example I wanted to throw out there is if hospitalization is required despite maybe a patient's objection due to a lack of capacity, explain why capacity was found impaired, what criteria were used, what steps will restore that autonomy, and how reassessment will occur. Even protective decisions must be explained with dignity. An ethical framework does not eliminate complexity, but it provides a disciplined, transparent path through it. So real quickly, because I want to make sure we have time for question and answers, we have a slide on practical tools and documentation. So structured capacity assessment, start with a very structured capacity assessment template. And a standardized approach generally promotes thoroughness and minimizes bias, and by ensuring we consistently evaluate the 4 core elements of decision-making capacity. And so again, that goes back to understanding. Can the patient explain the procedure and its risks? Appreciation. Do they acknowledge their diagnosis and the consequences of accepting or refusing care? Reasoning. Can we compare options and explain their rationale in a way that aligns with their values? And communication. Can they express a stable, consistent choice? A simple template should include the specific decision under consideration, a clinical context such as diagnosis, medication, psychiatric symptoms, pain, or acute conditions, reversible factors such as delirium, infection, intoxication, medication effects, and sleep deprivation, and lastly, a clear conclusion about whether the patient has or lacks capacity for that specific decision at that specific time. Remember, capacity is dynamic. Reassessment should be documented. Structured templates protect against subjective or overly broad conclusion. Next, I will advocate that documentation language matters. We want to avoid any vague phrases like patients confused or family making decisions. Instead, document your reasoning. Language is a very powerful tool because if capacity is intact, clearly state that the patient demonstrates that understanding, appreciation, reasoning, and consistent choice, and therefore has capacity for the decision. If capacity is impaired, specify why. For example, inability to appreciate consequences due to acute delirium with inconsistent or illogical responses. Note that the reassessment is planned. When a surrogate is involved, document verification of the authority, such as a medical power of attorney. Identify the surrogate by name and specify whether the decision reflects a substituted judgment or known patient wishes. In emergencies, document the lack of capacity or absence of a surrogate and the immediate need to prevent harm, invoking the emergency exception to informed consent. Precise documentation demonstrates ethical reasoning, not just clinical action. Now, consider guardianship red flags. Clinicians are often the first to notice when a guardian may not be acting in the patient's best interest. Warning signs include restricting visitation without medical justification, financial irregularities, refusal of necessary treatment without reasonable basis, living conditions inconsistent with available resources, isolation from advocacy or independent evaluation, or financial benefit tied to limiting care. If abuse or exploitation is suspected, healthcare professionals may have an ethical and sometimes mandatory duty to report. For example, in Texas, concerns can be reported to our, Adult Protective Services. Failure to respond to these red flags creates both ethical and legal risk. So finally, know your resources. For guardianship procedures or court guidance, consult your local legal court systems. Maybe it's a judicial branch or a probate court, something of that example. For advocacy and education, organizations such as disability rights. I'm going to reference things here in Texas, but Disability Rights Texas and Texas Legal Services Center. But there are also is the National Disability Rights Network that provides such valuable support. And for our military and veteran populations, resources can include the VA, DHA, or the Defense Health Agency, also the Social Security Administration. These systems help clarify procedural safeguards and may offer alternatives to guardianship. Ethical practice is strengthened, not just by what we decide, but by how we operationalize and document these decisions. So just as a few takeaways, did you want to add anything, Lorna?
Yes, but I'm having problem with the slide advancing. My apologies.
Well, as she begins,
Okay,
oh, there we
so
go.
here
There
we
you go.
go. Sorry about that, the little technical difficulties. So I'm going to end our session today by just going over some key takeaways. What's important for us is that ethical decision making when informed consent cannot be obtained requires more than clinical judgment. It does require discipline, ethical reasoning, legal awareness, and a commitment to preserving human dignity. Throughout this webinar, we have examined the distinction between capacity and competency, the elements of valid informed consent, substitute decision-making standards, guardianship processes and risks, and practical tools to guide consistent, defensible practice. At the core of every intervention is a balance, respecting autonomy while fulfilling our obligations of beneficence, non-maleficence, justice, and fidelity. When patients cannot speak fully for themselves, our responsibility does not diminish, it intensifies. We must assess capacity carefully, pursue least restrictive alternatives, verify surrogate authority, document clearly, and communicate transparently. Guardianship may sometimes be necessary, but it should never be the default when supportive options exist. Ultimately, ethical practice in these situations protects not only patients, but also families, providers, and institutions. Ethical practice strengthens trust. It reduces risks and ensures that even in the absence of direct consent, care remains patient-centered, right-respecting, and ethically sound. The goal is not simply to make decisions for patients, but to safeguard their voice, their values, and their dignity in every stage of care. So with that, I want to thank all of you for participating in this webinar, and we will now open for questions and discussions.
I will say some of you in the chat gave us some really, really good scenarios and examples. I hope I attended to them uh, sufficiently. But if there are additional questions, feel free to throw them out at us, and we can help you out in those last few minutes.
And Dr. Franklin, since we have a few minutes here and as questions are coming through, if you can go over maybe just one or two scenarios that you responded to,
Yeah.
um, that would be helpful as folks are typing in. And just please note, we have about 10 more minutes. And so in 10 more minutes, I'm going to go over, or I say 10 more minutes, in a few minutes, I'm going to go over the CEU information, but I just do want to open it up if there are questions for folks. And Dr. Franklin, if you wanted to address
Yeah.
just maybe one or two of the scenarios.
So I'll go. Dev had a really good one. And for those that can see the chat, great. I'll read it real quickly. There is a veteran's widow in Show Low, Arizona. The veteran was enrolled in the Phoenix VA. The widow is my aunt by marriage. Her neighbors have obtained her belongings by coercion and are having an auction in White Mountain Lake, Arizona soon. They have moved her into an assisted living or a nursing home. She is no longer taking my calls. She's 90 years old. She has macular degenerative vision and has a stamp with her name on it. She uses a cane and is frail with ambulatory issues. I have hired a lawyer at one point, and I was on her as a trustee along with the neighbor. He has since had her remove me and has taken control of everything. Is there anyone in that area that can assist? He has bullied her and had convinced her he is her only choice. She has two grandsons that she will not talk to. I do not want any of her money or belongings. I am sure the family would agree to donate monies to the local veteran agency to prevent the neighbor from getting anything. This could also be Medicare fraud hiding her money. So number one, it's a very sensitive situation, and I wanted to start with that because the we have a lot of veterans and especially in veteran widows. Just full disclosure, my mom is a veteran widow as well. And so this to me does the response that I gave in short basically says there is this distinction between the capacity and the competency piece here, but it also highlights how vulnerable adults' functional capacity can be compromised by coercion and isolation. So this could potentially be, a legal or a situation where maybe adult protective services could come in and do a consultation or an evaluation if you had pertinent concerns and if you had lots of information. So since we can't give legal advice, this is why I'm always using APS, or in the cases of CPS, we don't always have to call them to report things. Sometimes we're just calling them to consult and say, is this a dynamic at play that constitutes compromising somebody's capacity by coercion or isolation? And this pivotal legal situation puts, in this particular case, I think you said your aunt, in a very unique, precarious situation. But I think if you reached out to Adult Protective Services, I think they would be able to provide you some clear definitions by your state law. You can include all collateral reports. Again, these are suspicions. These are things that you're aware of, and if they're objectively captured, that's even better for any type of evaluation. But it sounds like your scenario could definitely be handled by your local state adult protective service because the individual in question is 90 years old. And so if you feel like that to be a benefit, I would definitely want to take action on that because it clearly you're witness to that coercion and isolation. Um, and hopefully, I don't know, I'm hoping that helped. Um, I,
Thanks, Dr.
another,
Franklin.
no problem.
We had
I'm
a
jumping through.
Yeah, no, we had
Keep going.
a quick question from Tiffany, and then we'll probably have to hop into our upcoming events and CE information real fast. But Tiffany asked, are there review committees within organizations that look at notes or justifications for guardianship and decisions around informed consent?
Oh my.
This is Lorna. I'm not sure. So every organization have policies and procedures regarding informed consent. If you are reviewing a patient's record and you are concerned as to what you're reading, um, you may want to escalate that to your supervisor. You may want to talk to the provider. Um, you may want to include your risk management department. Documentation is one of those things where if it's in doubt, I typically would just speak with the person who document uh, documentation I'm reading. I say, hey, I was looking at patient so and so's record, and I just need clarification what I read. This is what I read. This is my understanding. Am I correct? Because sometimes maybe they documented in the wrong patient's record. We don't know that. And that would provide them with that ability to reread their notes and to make the necessary correction if need be. So that's where I would start in terms of something like that. But there's always policies and procedures that you should reference whenever you are in doubt as to what it is you're reading and escalate it to the next step if indeed you feel this is a violation of a patient's rights.
There are also most larger entities have either ethics committees or
Mhm.
risk management departments. Those are really good places to kind of bring this to highlight.
Yes.
Thank
Always, I've always, for me, my ethics committee is on my speed dial
Mhm.
because complex situation, or whether it's a documentation, whether it's my engagement or involvement with a family, when you have these ethical dilemmas and they're not easy to resolve, consult your ethics committee. That's what they're there for, to help guide you through these complex decisions.
Thank you, Miss Riley, and thank you, Dr. Franklin. We have about 5 minutes, and so I'm going to have to go quickly through the next few slides just to wrap up. And we appreciate all of your just comments, scenarios, personal experiences that you've gone through, and I appreciate Miss Riley and Dr. Franklin for sharing y'all's expertise in today's important topic. We appreciate your time, and please know that for those of you that are on this is recorded. So after today, give us about a day or two to get the recording posted on our event page. So the page that contains all this information will also be the page where you find the recording. And so if you miss something or if you're wanting just the information, or if you know of a colleague that may have missed today's and you thought it was an important session to share, feel free to share the event page link with them, and CEs are still going to be available. We are providing 1.5 CE credits for today's webinar, which you can see a great list of accrediting associations that are we're offering CE credit from. But please also note, if you're just needing a general certificate of attendance to share with your supervisor or to have a record of, we also provide that general certificate of attendance. I went ahead and posted in the chat links to the event page again. If you scroll down to the continue education section of the event page, there's going to be a nice purple button that directs you to the survey. I went ahead and also put it a direct link to that survey. You'll need to complete a survey first, and then you'll be prompted to a page where you select which CE or certificate of attendance you're wanting. And from there, you should have an automatically generated email certificate once you complete all the prompts. If you have any questions or concerns, I went ahead and popped in my email address in the chat. So if you reach out, you have any tech issues, feel free to contact me. I'm happy to help in any way I can after today. Okay, so our next upcoming event or webinar for our lifespan caregiving group is going to be on April 29th. So we could go to the next slide, April 29th. We're going to be focusing on individuals with intellectual and developmental disabilities and military families and as they age well. And so we're going to examine age-related health needs, living arrangements, family caregiving, and practical strategies for supporting this unique population. And so please join us for our session on April 29th. We're offering free CEs for that event as well. And then also, if you are interested in our direct to learning um, information, so this isn't a live webinar, this is an actual um, program that we have available where any of our providers and family members can take part of. It's direct to learning and it's going to be focusing on Medicare Made Simple. and it's what caregivers and providers need to know. And so I'll go ahead and pop that link in here shortly in the chat. But really, this 60-minute session just is going to go over the different parts of Medicare, and then provide some great resources for caregivers and providers. And so this is a standalone program that you can watch at any point and get CE credits, or you can share with the caregivers that you work with as well. All right, we're just going through these real fast, so I apologize if we're kind of talking a little fast. Um, Join us for any of our upcoming events. We cover topics as it relates to personal finance, nutrition, lifespan caregiving, spouse employment. So get connected with all of our OneOp resources. It's just oneop.org, or you can scan the QR code here to join our mailing list, and we'll send you out all information on the program, the OneOp program. So get connected with us. I think there was a question about my email again and the link to the survey. So let me bring that closer to the top of the chat so you can see that again. So let me go ahead and post that in here again. But you can find all this information on today's event page. All right, so we have reached our 90-minute session mark. We appreciate you joining us. We appreciate our wonderful expert presenters for today, and our OneOp group for hosting us, and providing some great information for our providers. Have a wonderful rest of the day wherever you are, whichever state you are, or if you're Oconus, we hope you have a wonderful day or evening. And hopefully see you on another OneUp event. Thanks, everyone.